So now I'd like to introduce our speaker panel for tonight. So sitting right here to my right is Shannon Jackson. She is a certified coder, has been practicing in the Austin area for has 25 years experience. She currently has her own company called Code to Complete, but before that she'd worked with Seton for many years, as well as with AMPM and Purity, whom I know well. We're very, very pleased to have her here giving us her expertise. Sitting next to her is Dr. Peggy Russell, who is the founder and president of Austin Geriatric Specialists for over 25 years, which is the best geriatric practice I've ever seen. And she also was a Travis County Medical Society president, former president of Texas Medical Directors Association, and many other accolades. And she's my former partner until she retired, which was December 31st, 2015. Can't forget that. You want to come back? And so we're very pleased to have her and all of her expertise. And then to her right is Dr. Michelle Owens. She is a graduate of the family practice residency here in town, and actually many years ago was one of Dr. Russell's and my students when we taught their geriatrics. She then left because we did not have a palliative care fellowship, and that was her that was her career goal. She went to UT Southwestern and did a fellowship down there, up there with Dr. David Rubin, got her certification in hospice and palliative medicine, and came back, and it was the inaugural section chief at Baylor Scott & White Round Rock here, and has been there for 2.5 years. So we're very pleased to have such an illustrious speaker panel. I would like to go ahead and give the microphone over to Dr. Michelle Owens. She's going to be giving us the initial presentation, and then we'll be having questions and comments and all of that. Thank you.
Good evening. So tonight we're going to talk about incorporating advanced care planning into your practice. Our objectives will be to discuss the importance of advanced directives, identify the 4 types of advanced directives in Texas, discuss what things to consider when completing them, and then also explain the advanced care planning codes used to bill for these discussions, as well as the documentation required. So what is advanced care planning? So the definition is it's a process for directing medical treatment at a time in the future when you can no longer make your wishes known. It involves conversations obviously between you and your family and your healthcare providers. Ideally, these conversations are done when you're relatively healthy and not under the stress of finding out of a new diagnosis or bad news about your health, and obviously when you have sound mind. And it's a gift that I tell my patients that you give to your family in the event that you are unable to make decisions about your medical treatments in the future. So why is this important? Well, obviously people are living longer than ever before, but at some point we don't live forever. Most people will pass through a hospital and or a nursing home in the last year before they die. And it's important to plan for the future. We plan for a lot of other things, so our health should not be something that we leave out. So often when I'm bringing up these conversations, I'll say, in the event you are unable to communicate with your family and doctors due to illness or trauma, number 1, who would be your voice and know what decisions that you would want? And number 2, what would those decisions be? So who should complete their advanced directives? Everyone in this room. I have my directives completed. Really anybody who drives on I-35 or downtown or anywhere, you should have them done. You don't know what's going to happen. But especially our patients living with serious illnesses. So these are patients that have advanced heart or lung disease, patients with end-stage renal disease on dialysis, advanced malignancy, any geriatric patients with physical debility and frailty, and any patients having surgery, because we know these patients are going to be put under general anesthesia and things can change. So, you may ask yourself this, or your patients may say, well, what if I don't have advanced directives? Then what happens? Well, per Texas law, a surrogate decision maker would be responsible for making medical decisions on your behalf if you had not elected a medical power of attorney. We've seen some evidence that likely people undergo treatments that they do not want because there haven't been these conversations had earlier. And there's also increased burden and guilt on people that are asked to make these medical decisions. So this is a lot of small print, but this is the surrogate decision maker in Texas, pulled from our law. So basically, if you don't have a medical power of attorney elected, then it would default to your spouse. If you were widowed or you didn't have a spouse, it would default to a relatively available quorum of your adult children. And then it kind of just goes down to parents, individual clearly identified to act for the patient, and it can get really complicated if you haven't already elected who would be your voice. So like I said, there are 4 types of advanced directive documents in Texas. The first is the medical power of attorney, and we'll go over each of these, and I'll show you a picture of the documents as well. There's the directive to physicians, out-of-hospital DNR, and just recently we had a Senate bill passed that you have to complete an in-hospital DNR form as well. So for the medical power of attorney, this is the legal document that allows you to name a person who would be your voice in the event that you could not make medical decisions for yourself. It only goes into effect when you are no longer able to make medical decisions. So I have a lot of patients who say, well, I want to make my decisions. And I say, of course, we're always going to come to you. But if you couldn't make those decisions, if you were in an accident or if you had altered mental status, who would know your wishes? So this is what the medical power of attorney looks like for our system. You can find different ones on the web, or your system may have something differently. But basically, you can elect one person to be your medical power of attorney and then list up to 2 alternates. Also on that form, you can put where the form is going to be kept, and then we usually have it scanned into our electronic medical record so that it can be easily accessed in the event somebody is in the ER or admitted in the hospital. The second form is called the Directive to Physicians and Family, or the Living Will. This is the document that allows you to state your basic goals for medical treatment and the intensity of what you would want it to be in the future when, number one, you couldn't make your medical decisions on your own, and your doctor has certified that you're terminally or irreversibly ill. Again, this one only goes into effect if you're no longer able to communicate. I tell my patients that it really kind of acts like a guide. So if you're admitted to the hospital and there's a doctor taking care of you who's never known you before, they're able to kind of know, based upon what situation you're in the hospital, if they're counseling your medical power of attorney of what decisions to make. So I tell people, at the end of your life, would you want aggressive treatment to keep you alive, like being on life support, a ventilator, or would you rather want to focus on your comfort and be allowed to die naturally? In addition, on this form, there's a space where you can also put additional wishes. So if there were specific treatments that you did or did not want, IV fluids, artificial nutrition, dialysis, donation of your organs or tissue. And then there's also a space that you can put who would be your medical power of attorney if you haven't already completed that form. And again, this is what the form looks like for our system. It's pretty similar if you just Google the Texas Living Will or Directive to Physicians form. So, a lot of people ask, well, what is a terminal condition? So per Texas law, it's defined as an incurable condition caused by injury, disease, or illness that according to reasonable medical judgment produces death in 6 months, even with available life-sustaining treatment, provided in accordance with the prevailing standard of medical care. So a bunch of words, basically, an example of that could be, a stage 4 malignancy, end-stage liver disease, end-stage heart failure, end-stage kidney disease, or end-stage lung disease. An irreversible condition, per Texas law, is defined as a condition, injury, or illness that, one, may be treated but is never cured or eliminated, and that leaves the person unable to care for or make decisions for that person's own self, and also, without life-sustaining treatment, provided in accordance with the prevailing standard of medical care, would be fatal. Examples of this could be some severe traumatic brain injuries, severe stroke, end-stage Alzheimer's dementia, stage 4 malignancy. The third document is an out-of-hospital do not resuscitate order. So this is a physician's order to not perform CPR, cardiac pacing, defibrillation or shocks, advanced airway management, and/or artificial ventilation. This form is different from the other two in the fact that a physician has to sign it. And it's the only document that in the state of Texas will prevent the paramedics from doing CPR if they're called. It's especially important for those who are terminally or irreversibly ill and who wish for a peaceful death. This is a document that when completed, the paramedics know to look on the refrigerator. So we tell our patients to put it on the refrigerator. Some people get a little sheepish about that, and so there are special tubes you can buy to put in the freezer. The biggest thing is just that whoever is gonna be there with you knows where the form is. And then we have other patients who frame multiple copies and put it around the house. So the most important thing is if you complete it, you know where it is. There are some people that go as far as to tattoo "do not resuscitate" on your chest. As far as I know, and I'm not a lawyer, I don't think that can, be held. It probably, if I was a paramedic, I would feel pretty guilty if I was doing CPR with that tattoo. But really, this is the only form that legally can protect you from not having CPR. And this is what this form looks like. This is the form for the state, so this is not specific to our system. So the fourth one, so this one was a Senate bill that was passed last April, and I believe there was a Business of Medicine that talked about that. So there's now an in-hospital "do not resuscitate" order form. For our system, we call it the Code Status Orders Validation Form. Every system may have a different form, which also makes it a little confusing. But it's basically the physician's order to not perform CPR while in the hospital. It has to be completed to prevent hospital staff from performing CPR. And again, it's especially important for people who are terminally or irreversibly ill and wish for a peaceful death. I bring this one up because depending upon your system, if I'm completing an out-of-hospital DNR for a patient, I will offer to also complete the in-hospital DNR. We're able to scan it in our system so that if they're admitted that it's already done for them, because it's kind of a laborious form to complete. So some things to consider when you're completing advanced directives. And this doesn't go just for what you're counseling your patients on. This is for you too when you're thinking about what am I going to do for my advanced directive, or I'm going to talk to my parents about their advanced directives, or my siblings, or your friends. Goals of care. We talk about this often, especially in the field of hospice and palliative medicine. So, what makes life worth living to you? What would you be willing to go through for a chance for more time? What would you not be willing to go through? What is quality of life to you? Different people will say different things. I've had some people tell me, as long as I can eat chocolate ice cream and watch football, that's a good quality of life to me. And sometimes that gives you more of an idea of what to do than saying, oh, I wouldn't want dialysis, or I wouldn't want this. Would you ever be okay if you had to live in a nursing facility? There are some patients that are very much against, I don't ever want to be in a facility, I only want to be home. Have you thought about how or where you'd want to be when you're at the end of your life? Do you want to die at home? Do you want to die in a facility? And who have you discussed these wishes with, and who would you trust to respect them? And that's really important because oftentimes I'll find that if people have completed their medical power of attorneys, sometimes they've never talked to the people that they've listed. And so then if we're in the ICU calling that medical power of attorney and they say, oh, well, I didn't know that I was listed, because they don't have to sign anything saying that they're listed. And then they don't know. They've never had those conversations. They don't know what that person would want. So, some pearls on how to start the conversation, right? That sounds daunting for a lot of people. This is something that I do every day, so it's not as difficult. But I tell people, especially around the holidays that just came, a lot of times you're around your family. And although it sounds a little morbid, that's a good time to bring it up. So, some things that you can say, what things are important to you? What concerns do you have about getting sick or needing medical care? If you were very sick, are there any specific medical treatments that might be too much? And really important, what are your spiritual, philosophical, cultural, or religious beliefs that would influence your medical decisions? And I think it's also important to note this is not a one-time event. These are conversations that really kind of happen over time, and as medical conditions change, they're important to revisit. But it's important to talk to your loved ones about what are your values and what's important to you. And again, they can be over multiple conversations. Some people will film themselves on their tablet or their iPhone just so that they have it kind of, a video that you can watch and know what's important to them. And then it's also really important to talk to your healthcare team, right? Talking to your physicians that are treating you, asking them, what would you recommend? What things should I go through? What should I not go through? And then obviously completing the legal documents to document your wishes. So these are just some things that I tell my patients when we discuss advanced care planning. So I always tell them that I'm not bringing this up because you have stage 4 cancer or advanced heart disease, but I'm bringing this up because rather we should all have these conversations and documents completed, and I have mine completed. I often say if you drive on I-35 or I'm up by the outlet, so if you drive on University Boulevard, any of those places are high traffic areas and you just don't know. None of these documents are set in stone. They can be revised at any time. They can be ripped up and kind of be void. They never take place of your voice. Again, that's another reason that I think a lot of people tell me that they don't want to complete them. Well, I don't want somebody else to make decisions for me. So again, they don't go into effect unless you are not able to make decisions for yourself. And then also, completing the documents are important, but most importantly is having the conversations around them. Because if you just complete them and you don't talk to anybody about them, then they're really kind of null and void. I mean, they don't help anybody. So, if you spend this time, having these conversations with your patients, it's always nice in this day and age to be compensated for it, for your time, and for, these are hard conversations to have. So there are advanced care planning codes. They must be face-to-face with the patient or the surrogate. These are discussions that are regarding reviewing and refining goals of care, deciding about options for treatment, discussing advanced directives, designating a proxy, and then completing the forms. CMS did not impose a limit as to the number of times the code can be billed, and there's no place of service limitation. So they can be inpatient, outpatient in your clinic, at a nursing facility. They're not limited to particular physician specialties, and they may be billed independently by a physician, a nurse practitioner or PA, or a licensed clinical social worker. With these codes, they can be billed during the annual Medicare wellness visit, and then, particularly in my specialty, I may bill these codes multiple times during the week because we're having ongoing conversations if people are in the hospital and things are changing from day to day. So the codes are, there's the CPT code 99497. This is to be billed for the first 30 minutes. So at least 16 minutes need to be spent discussing complex care planning. The CPT code 99498 is for each additional 30 minutes. So if you spend at least 46 minutes discussing complex care planning, that you would bill in 99497 and a 99498, excuse me. And if you spent 76 minutes, you would bill in 99497 and then two 99498s. Not many people in their outpatient practice are going to be billing for that long of a conversation, but for example, I might bill that if I have an hour-and-a-half conversation or family meeting about a patient whose loved one is on a ventilator after having CPR, after having a cardiac arrest. An ICU attending may bill for that. So there can be different specialties that might spend that much time with it, but that's more of a rarity that you're going to bill it that many times. So there's no specific format required by CMS, but you should mention obviously who was present for the conversation, an account of what discussion you had with the patient or family members regarding the voluntary nature of the encounter. So they don't want you to coerce patients or families into having these conversations and billing for it. They have to be obviously amenable to having the conversation. An explanation of the advanced directives along with completion of forms when performed. It's important to know, though, you do not have to complete the advanced directives to bill the code. Just having the conversation around kind of the goals of care or the advanced directive counts. And then you have to document the time spent in minutes in the face-to-face encounter. So for example, this is a dot phrase that I have. We use Epic in our system. So this dot phrase I'm just able to quickly type in, and then I can tab through and put what we've discussed, so who they would want to be their medical power of attorney, whether or not we've completed the form or they've already completed it. We discussed the directive to physician and what their wishes are, and then also about the out-of-hospital DNR. And then at the bottom, I'm able to put the time spent discussing the complex care planning was so many minutes. So these are some common billing frequently asked questions. So does the patient need to be present? No, it can be with a surrogate. Obviously, if the patient is able to make decisions, they should be involved in the conversation. But if the patient is intubated on a ventilator, then you would be talking with the medical power of attorney or the surrogate. Can you provide this telephonically? No, it must be a face-to-face visit. Can more than one provider bill this code? Yes. So let's say again, I could see this happening more in an inpatient setting. So if you have the ICU attending, meeting with the patient and family and talking to them about something, and then you come back later and have another conversation about what they talked about, then you could potentially both bill it on the same day. Is there a limit to the physician specialty? No. Is there a limit to the number of codes billed? No, but the asterisk to that is that, you shouldn't be just having this conversation every day flippantly. And also for patients, if you're having the conversation, if you do it too often, sometimes it can kind of become almost too much like a fatigue of talking about the same thing over and over again. So really, you would only want to have that conversation again if something really changed. And then can the ACP codes be billed together with routine hospital, office visit, or E&M charges? And yes. So if you had an outpatient visit, you could bill your normal E&M office code for that along with the ACP code with the appropriate documentation. These are just some patient and provider resources that can be helpful. The second one, the Stanford Letter, I don't know if anybody's heard about that. This came out of Stanford, the palliative care department there, and you can actually go in and kind of address a letter to your primary care physician or whatever physician that you would like to, saying kind of what your wishes are. It's in multiple different languages, and so different people can go in. It kind of is a prompt for them to have those conversations. Similar to the 5 wishes, which is something that is used in other states, but it's not a legal document here in Texas. But those are just some good resources for you or for your patients. And then, if somebody asks you, or maybe you're asking yourself, well, why should I complete these forms? Again, it's a gift that you give to your family to take the burden off of them by sharing your wishes. There's been evidence to show that having an advanced directive is associated with less suffering at the end of life, less frequent hospitalizations, improved patient and family satisfaction, and lower costs of treatments. And in the absence of advanced care planning, families find making these decisions for their loved ones to be the most stressful decisions in life. Many family members suffer with guilt as to whether or not they've made the right decision for their loved one. I had a patient earlier this week that I saw who has a new, stage 4 malignancy, and then had a cardiac arrest and is in the ICU, and I met with his medical power of attorney, and this is the 4th loved one that she's had to, in essence, she said, make the decision to take them off life support. And there was no directive to physician or living will completed by this patient. And so for her, she really felt like she was having to make that decision. And you could see just the guilt and the burden that was weighing on her. And so again, it's really a gift that you give. Even though it's hard to have these conversations, most people, once we've had them and we've documented them, they really feel like there's been a weight lifted. And you can talk about it a little bit more freely. So, any questions?
Do you ever get into, because patients don't know about CPR and the statistics of, how the chances are so low of you leaving the hospital the same person you came in. Mm-hmm. Do you get into any of those specifics with them?
So, my kind of usual, what I say is CPR is generally the most successful in young and otherwise healthy individuals. And I say as we get older and we have more medical problems, the chances of having CPR be successful are very low. And then I'll say, for example, for patients who have stage 4, kidney cancer, the chances of you surviving CPR are very low, and if you did, you'd most likely end up in the ICU on life support. And usually I talk about the out-of-hospital DNR after I've talked about medical power of attorney and directive to physician. So if they've already said, oh no, I wouldn't want to be kept alive on life support, I'll say, and you've said that that's not something that you would want. And so my recommendation to you would be that we do everything else that we're doing, but if your heart stops or your lungs stop, and especially if people are religious, I'll say, and if God calls you home, I think that we let God call you home and we don't try to bring you back and have you end up someplace that you wouldn't want to be. And usually that's well received. But oftentimes this has to be a conversation that happens a couple times, or I'll give them extra information about CPR and the statistics if they need that. Yes, sir.
Maybe I missed it, but is there anything that you carry with you, like on your driver's license or something, that can indicate with the codes what your status is? Or?
So my understanding is that there's not is there a particular wallet card that you're aware of?
The bracelet you can get, if you go to the Texas Health and Human Services website, you can get a DNR bracelet and wear that. We've had a few patients do that. That's again another thing that EMTs will respect. But the example of the DNR on your chest tattooed, it's not officially endorsed. We joke about it kind of morbidly, like, oh, do you have to have signed it too? But the best thing is really to have a copy of your DNR. Again, the bracelet can work. We haven't seen that as much lately.
Do people look at those? Because I wear a bracelet, I go to the hospital, They don't look at it.
Is it one of the official ones?
It's not a DNR bracelet, no, it's got my other medical problems, but.
Right, so this would be an official,
DNR on it.
yeah, this is an official one. I mean, it's pretty simple. That comes from the state of Texas, from Health and Human Services. And that, I'll be honest with you, we've never trusted that. And so as a physician, when we've had anyone, we've got the paperwork too. And I've usually, when I've been participating where EMT is, I make sure I'm the one holding the DNR in front of them. But theoretically, they're supposed to honor that.
Maybe a silly question, but so before I'm taking like a 98-year-old to surgery, what should I be asking? And most of my surgeries are outpatient, but I guess you never know. Should I be asking them specifically if they have some of these forms? Or like what should specifically I ask? Like when I'm not even when I'm in the surgery getting consent, but when I'm in the clinic and they're, we're just talking about surgery, should I be bringing this up? And like what should I specifically ask?
I mean, I would say definitely. I mean, as a 98-year-old patient, for sure. I mean, even a 35-year-old patient, you never know, right? I would just say, have you ever completed any advanced directives before? Most people who have completed them know what that means. Or you could say medical power of attorney, living will. If they say, no, I haven't, it would be nice to have a copy of those documents to maybe give to them, to where they could look them over and complete them prior to having surgery. Because again, I mean, especially if it's an elderly patient, God forbid something happens and they're ending up in the ICU, I think it's always good to know who to call and if they have any wishes documented. I don't know if there's anything else y'all would add.
The other thing you can look at is what's called sort of the procedural DNR. We've tried our specialties trying to get away from that and more goal directed. So instead of, are you a category 2 and do you want pressors but no CPR, that kind of thing. Instead of not doing that, but saying, hey, what are your goals? Do you want to, if you're very, very sick, we can tell you that if you get CPR, you're going to end up, even if you survive, you'll be sicker than you were before. But for something like that, that may be a situation where procedural DNR discussion may be helpful, not to try and complicate it. But, if you have someone, that may be where you might almost want to get into that, where we used to be like, well, would you want pressors? Would you want to be intubated? And when they're in I would imagine in a facility, even an outpatient surgical center, potentially, that you could honor that. CPR was developed as a resuscitation effort for anesthesia-related problems in surgery, and it worked well. So if you have an 80-year-old who has all of a sudden an arrhythmia because of too much anesthesia or something that can be reversed easily, you want to, you want to be able to have that kind of discussion theoretically. You'll have some 98-year-olds who will say, forget it, if that happens, I'm gone. But that, I would encourage you to try and have that level of conversation if you can.
Yes, ma'am.
Does the doctor have to initiate the conversation because it says the social worker? So if I have an independent social worker who comes in and starts the conversation and finishes it, does the doctor have to initiate it?
So basically it follows the rest of the professional Medicare fee schedule. It falls under incident 2 rules. So if you start it, introduce them, and they come in and do it, it's billed under incident 2 rules.
Yes, ma'am.
I know there used to be like TexasLivingWill.org where you could do everything online. Can you do these things online now, or do they have to be signed in front of a notary?
They have to, my understanding, they have to be signed either by 2 witnesses or by a notary. Yeah. Yes, ma'am.
Physician starts that conversation in a regular visit, and then they introduce them to the nurse or the care manager, and then they finish the discussion. Can that be an RN? Does it have to be, can it be an LVN?
Yes. Anything that you would bill incident 2, so think of something that you would give an injection. That's an incident 2 service. Anybody that's able to do that, yes, you can.
And does the physician need to be there over half that time, or
No.
just be they can start the discussion?
They can start the discussion, introduce the nurse. That's only in the outpatient setting. That is not in the inpatient setting, because incident 2 rules do not apply ever for anything in a facility setting.
One other
other nice thing that I don't know how much it applies to you all, but these codes require a face-to-face visit, but not with the patient. So if you are in a situation, and as a geriatrician, this happens not all that infrequently, where the family wants to meet to talk to, this is the kind of thing, prognosis and that, and it used to be, you can't bill for that because the patient's not there. You can bill this code, and you can bill, for however long. So again, just something to keep in mind. You could actually bring your patient's family in and have a visit.
Does this have to really just address the issues, just address the forms, or can you have other discussions related to end of life, or like in a tool of Wanda's being mortal, he has a whole discussion prior to end of life discussion where he talks about what do you want to experience life, what are your joys, what do you not want to experience, what are your trade-offs, and that's really a discussion before you get to the point of having invoked your medical power of attorney. But I think those are important conversations about can we bill, your code for that kind of conversation, or does it really have to involve end of life?
Well, no, I think that that's definitely part of the conversation that gets you even to the advanced directives. Generally, I feel I'm unsuccessful if I just jump into who's your medical power of attorney, right? This is usually after, my new consults are 80 minutes long, so maybe for the first half hour I found out where they're from, who they are, what they like to do, what's important to them, what they understand is going on with their medical condition, and then I'll bring up the directive. So, no, I think that's a very important part, and that's considered, I think, the complex care planning portion of it, right? Asking them, what would you be willing to go through, what would you not?
No forms have to be signed to bill this code. You don't even have to have gotten to the point where you've decided which way you're going to go.
Right.
So, any of that is billable under this.
And ultimately, oftentimes you have multiple conversations before the forms are even completed. Yes, sir.
If you have a patient with an end-stage disease and you know that they're already involved in hospice, should we assume that all this has been taken care of by hospice?
Oh, that's a loaded question, I think.
Is it a good idea to check on that? Or because I think most of us feel like if they're in hospice, they probably have already had all these questions.
You would sure hope that if they've decided to pursue hospice, hospice care, that those conversations have been had and that they understand that they're just focusing on comfort. I don't think that it's ever wrong to ask somebody. I think people usually welcome these conversations, even though we usually feel uncomfortable bringing them up. But
Yeah, I see people on hospice who, especially with consultants, they have everything done, but they're gonna go to their cardiologist. And what they're really wanting, whether they're able to vocalize it, is they want to know the cardiologist agrees with the plan of care as well. And so sometimes that's, kind of thinking, is that why they're coming back? You're in hospice now, but here they have an appointment in your clinic again. It may be that they need you to, all of us have second guess ourselves on all kinds of decisions, and this is nothing different. It needs, constant reflection and reassurance, and so sometimes that's what it is, and patients are often not very forthcoming about why they're there. So I would take that opportunity again to see what's on their mind.
I also think there's a certain percentage of hospice patients who remain a full code. I don't know what the number is, 10%?
Probably.
And some of the reasons that they do that is, the disconnect between the hospice services and their primary care physician, or the person who was dominant in their care, a specialist or their primary care doctor, they haven't really gotten the ultimate prognosis and the ultimate discussion with that physician. And so what I always found in hospice was that once the patient's physician was able to talk to them and their family after they were on hospice, if they were still remained a full code, that was one of the most significant discussions in helping them decide if they wanted to remain a full code, and most didn't.
I think another thing too is there's still, I think, the fallacy of thinking that signing a DNR means do not treat. So I think oftentimes I'm having to say, like, we're still going to do everything else. It's just that when you die and your heart stops and your lungs stop, we are not going to put you through those aggressive measures. But I think a lot of people will not sign it because of that. Or sometimes it's cultural reasons, there can be all kinds of reasons sometimes, and it just takes that time to kind of delve in and kind of figure out what their hesitation is, right? And sometimes I'll just ask, what makes you worried about signing that form, or what are your concerns? Yes, sir.
Sorry, excuse me, the DNR form that you sign for hospital, you bundled everything together, CPR, defibrillation, this. Each of them has a separate weight. So I'm not sure if they're signing the DNR, you have to bundle up all of this, or you can separate them?
So for our form in the hospital, there is the option to you can be full code, right? You don't have to sign anything. And then there's the DNAR, so do not attempt resuscitation and continue other treatment, or we have do not attempt resuscitation, allow natural death. And then we have a limited code. The limited code, though, generally is one where it's kind of cherry picking. I want to be intubated, but I don't want CPR, or I don't want this, or I don't want that. Usually, I find that the limited code is not super helpful. It's kind of more of going back to that goals of care, what are we hoping to get from this? I think if maybe your concern was they were going to have VTAC, and that could be something that was reversed, then you would maybe approach that with them a little bit differently. But if it's a 99-year-old with stage 4 cancer, even if they have VTAC, are we going to shock them? I don't know. I think that it's a much bigger conversation than just kind of picking which ones they would or wouldn't want to have. I don't know if y'all have anything else to add to that.
Yeah, just to some of that. The Texas out-of-hospital DNR does not have options. It is, you are no basic life support or ACLS. That's that. In the hospital, in some ways it's done to try and allow physicians to still have, some decision-making in there and shared decision-making with their patients about things like that. In my personal experience, the only time the limited code is helpful is in a surgical situation. Someone who does not want to be resuscitated but is going in for surgery and has a good chance of coming out, but what if something happened in the surgery, and then kind of trying to think through that with the team and coming up with a contingency plan for that. But even then, when I start talking about people who are like, well, I would like to be shocked, that's a sign to me that, they probably still want to be full code. And what I want to then focus on is, okay, let's say that you were resuscitated, what would be an acceptable quality of life? How long would you want to be on a ventilator type thing? You're going to be safer doing that rather than someone who's not sure about something,
Any other questions? Yes, sir.
You covered what we've said applies easily, I think, to people over the age of 65, 70, 80, whatever. But what about people under the age of 30, children and that? Is there anything that's ever, because some of them have terminal illness.
Right, so I think that Well, I think you have the same conversations either with them. If they're children, then you have the conversations with their primary caregiver or their decision maker, right, which is usually going to be the parents. If it's a young patient, over 18 that has a malignancy or another terminal condition, then you talk to them just as you talk to somebody over 65. What's important to you? What makes your life worth living? Because, oftentimes I think we think that people who are younger don't understand, or they don't have as much insight into what's going on, but they know if you ask.
The one exception is in the state of Texas, if you have a pregnant patient, they are not legally allowed to be a DNR. And that's based on statutory law, not case law, but that's been how it's been held up. So that's not true in every state.
I'd say that one thing that I do with my younger patients is my 30-year-olds, that kind of bring it up to them as well. But I also ask them if they're married, they have kids, about actually doing their estate planning and their wills and all of that, and tie it all in that conversation. And they need to make sure they're taking care of that, all those legal questions and planning along those lines too. I think it's a good way to wrap it all together.
No, for sure. And then I think over time, right, I mean, if you have a longitudinal relationship with that patient, 10 years from now or something changes in their medical condition, then you can revisit the conversations as well. Yes, sir.
A situation where there's a patient who is terminal, utterly terminal, and does not want to be on.
Well, you can't force anyone to do it. So if they're in your office and they're terminal and you see that, they're hospice appropriate and they don't have much time left, I mean, you can't force anybody to do something they don't want to do.
Specifically in the hospital.
At St. David's, there was a procedure for calling a committee to deal with the issue. When you have a patient who has no surrogates, is alone in the world, and is on the verge of death, but yet refuses to be a DNR.
I believe you're referring to like the ethics 166046, where you have two physicians who have to certify that the patient's terminal, if there isn't any documentation or there isn't somebody to speak on their behalf. But I think if the patient has capacity, I mean, it's very difficult, at least in my experience in the state of Texas, to really force somebody to become DNR. And that's one of the reasons why this Senate bill was passed last year, is that there were some concerns that there were unilateral DNRs being made in the hospital by physicians not talking to patients. So I don't know if y'all have anything else to add to that, but I think it's just a hard situation.
Yes, I can't imagine that actually ever happening, but that is why the law came. But yes, I think if someone has capacity, then you can't override their decision making. CPR is one of the weird things where you're presumed to be full code until you say otherwise. So if they're not willing to say otherwise, then they are full code.
Where do you get those freezer tubes?
Oh, where do you get the freezer tubes? I'm not sure. I've just heard patients tell me that they have them. It's probably some QVC thing in the middle of the night or something. I don't know. Any other questions? I'll show y'all, I have just a couple references here. These are just some additional readings and resources that I've found to be helpful during my career. Some different books, one you had mentioned about Atul Gawande, and some other just organizations where you can get more information, and then just a little humor.
In case anyone's curious what the codes pay, in 2019 Medicare fee-for-service for Austin, there's a slight downgrade for if you're in a facility. If you're in an outpatient clinic, it's about $86.19 for a physician for the first 30 minutes, and then $75.69 for each additional. In a facility, that gets changed to $79 and change and $75 and change.
And for RVUs, if anybody's on a production-based plan, I mean, I believe it's 1.5 RVUs for 99497 and 1.4 for 99498.
Well, thank you all for coming tonight.
Thank you.